Welcome to this lecture for abnormal psychology. The topic today will be on assessment and diagnosis of abnormal behavior, and we'll also talk a little about research of abnormal behavior in psychopathology. Okay, overview of what we'll talk about in terms of assessment, about why we assess, different methods of assessment, a couple of issues in assessment. With related to diagnosis, similarly, why do we diagnose? Issues in classification and what our current system is for classification and diagnosis. And then in research, a brief review of key concepts, and then some discussion of a few methodological approaches to doing research. Okay, key concepts in assessment. What is assessment and how is it different from diagnosis? Well, assessment is simply the systematic evaluation and measurement of data, of behavior, thoughts, feelings, whatever you're talking about. Now, your book says that assessment is something that psychological assessment in particular is something that is limited to someone who's presenting with a possible disorder. But that's not quite accurate. Psychological assessment is much broader and has more uses than simply to identify diagnoses. So anytime you're gathering data in a systematic fashion related to psychological functioning, well, that's psychological assessment. Okay, well, how does that differ from diagnosis? Well, diagnosis is a process of determining whether a problem meets criteria for a specific disorder, right? So it's a process for coming to a decision and then making that decision. And ultimately, the word diagnosis then applies to what the decision was, some sort of label. Or you have this diagnosis. That means somebody went through a process and determined that, yes, this label applies to you. You meet criteria to fit in this category. All right. Key concepts in assessment include reliability, which is all about precision, right? And reliability is the degree to which measurement is consistent or precise. So if we're shooting a bow and arrow, are you hitting the target in the same place every time? Now, you don't have to hit the correct place, where you're aiming, but are you hitting the same place every time? If so, that's reliable. And when it comes to assessment, am I getting the same answer when I use this assessment tool, methodology, or procedure? So the types of reliability we talk about include inter-rater reliability. So if we have doing some sort of behavioral observation, let's say, there's a kid playing on the playground, you're there to observe, you've got two colleagues with you, and you have some rules for your observation. Okay, aggression is defined as whatever, making physical contact with another child that's uninvited, whatever. You have some operational definition, and then you're supposed to follow that definition and rate how many times the kid is aggressive. Okay, so you're doing it, you're making your tally marks, and then so is your colleague and your other colleague. Now, do you all, in the end, agree? Do you have the same number of tally marks using the definition you had? So you have this definition, you saw the same thing, and you had the same rules about deciding whether or not the behavior was present, but using those rules, did you agree? The degree to which you agreed and you have the same answer, either all exactly the same answer or close to the same answer, is the degree to which you have inter-rater reliability, right? If your answers are vastly different, you have poor inter-rater reliability, which suggests either your raters aren't well trained or your assessment method is poor, it's ill-defined, it has poor validity, right? The instructions weren't clear enough, perhaps, in this behavioral measure. We also have test-retest reliability. So that's about over time. So if you are testing somebody today and you get a result, okay, they're this depressed, this aggressive, this happy, this friendly, whatever. When you test them the next day, a week later, a month later, are you getting the same result? And again, the degree to which you should get the same result over different periods of time depends on what you're measuring, right? Some things are thought to be fairly stable, right? So if you're measuring, say, intelligence, okay, if I measure intelligence today and I come back in 6 months and I measure it again, should get the same score if I've got a reliable measure. Now, if I'm measuring hunger, how hungry are you? And I measure your hunger right after lunch, not very hungry. And then I measure again the next day, but this time it's at 5 o'clock and you haven't eaten supper yet. I'm very hungry. I must have a bad measure. The number's different. No, that's supposed to be different because you're there's other things going on. So it depends on if you're measuring something that should change over time, and how far across time did I measure? Is it a day, a week, a month, a year later? How far something's supposed to be stable? Well, it depends on what we're measuring. But for a lot of things we'll look at, we're looking at traits which are thought to be fairly stable. And so even over the period of a couple of months, even years, we should see fairly similar scores if we have a reliable measure. Now, if you're getting vastly different scores across time, well, then you may have an unreliable measure. Third type of reliability that we talk about with assessment is internal consistency. And this is relating particularly to surveys or scales where you have multiple questions, multiple items that all measure the same thing, right? So if you're giving someone the Beck Depression Inventory 2, it's got several questions about depressive symptomatology. Now, if that measure has good internal consistency and you are very depressed, then you should look very depressed on most of the questions, right? So your answers to question 1 should correlate with your answers to question 2, 3, 4, 5, 6, on down the line. They all should correlate with each other. You shouldn't look very depressed on this question and not depressed at all on this question. If that happens, you don't have good internal reliability. And again, depends on what you're measuring. When you're measuring something that is a kind of a unitary construct, it's one thing, yeah, they should all be the same. If it's a multifaceted construct, well, you could be high on this but low on this and medium on this, well, then that makes sense. So again, lots of things that are matter of degree and matter of perspective. So if reliability is about precision, are you hitting the same spot every time? Validity is related, but a little different. It's about accuracy. Are you hitting what you intend to hit? And when it comes to assessment, are you assessing what you say you are assessing, right? So I've got this measure of aggression, let's say, and let's say when I give somebody this measure, they look real aggressive. I give them the measure a week later, they still look real aggressive. Okay, that's good. Retest reliability. They don't. They get a high score. They get a high score again later. But then I figure out, okay, this measure of aggression, people who score very high on it also score very high on a measure of creativity. Okay, well, the constructs, the ideas of aggression and creativity aren't related, and so high scores on one shouldn't be correlated with high scores on another. Now, there'll be 1 or 2 people that are high in both, sure, but across groups of people, you shouldn't see a correlation. We want those things to diverge. So we want those two measures of those two constructs to be unrelated, and if they are, we've got good divergent validity. If they're not, if they shouldn't be related, but they are, then we've got poor divergent validity. Flip side of that, convergent validity. So we have a measure of our construct, let's say aggression, and then we have a measure of another construct that's related to it. Maybe we have some other measure of tendency towards violence or difficulty maintaining temper, right? Okay, so that's not the same thing, but it's a related construct. High scores on one should correlate with high scores on the other. Low scores on one should correlate with low scores on the other. And if they do, then I've got good convergent validity, right? Where my method of assessing one construct is related in a systematic way, the way it should be, to the measure of another construct. So that's construct validity. Criterion validity is very similar, but instead of a measure of a construct being related to a measure of another construct, you have a measure of the construct you're interested in. So again, let's say we have our measure of aggression. So we've got a measure of a construct. Now we're looking at, is it related to some criterion? Now, a criterion isn't a construct, it's an outcome. So it's not representative of something necessarily. So let's say my construct is aggression. I'm measuring this propensity towards aggression. What's a criterion you could think of? What's an outcome that might predict? People who are high in aggression might do what? Well, they might get arrested more, or they might get sent to the principal's office more, depending on what age group we're talking about, right? So if we're talking about, if I measured how aggressive you are right now, and then I say, okay, do those scores right now, if I go and I look over the next 3 or 4 weeks, how many times did you get sent to the principal's office? If I can predict that criterion, that outcome well, then I've got good predictive criterion validity. Okay. Concurrent criterion validity, very similar, just looking at right now. So right now I've got this measure, this is how aggressive you are, and to date you've been sent to the principal's office this many times. Okay, then that's concurrent validity. So it's related to things I can measure at the same time. Predictive is looking at, okay, can I measure now, predict things, outcomes into the future. Okay, so an important thing about reliability and validity is to have one, you have to have the other. But for the other, you don't have to have the other. Okay, so is that confusing enough? To have validity, you've got to have reliability, right? If you're going to be measuring what you say you measure accurately, well, you've got to be reliable. But being reliable isn't enough, right? It's necessary but not sufficient for validity. If you have a scale at home as you weigh yourself on, and every day you get on that scale and it says you weigh 100 pounds, okay, it's incredibly reliable. But if you put your kids on there, your mother-in-law, everybody gets on there and it still says 100 pounds, it's clearly not accurate. Everybody doesn't weigh 100 pounds, but it's giving the same answer every time, so it is definitely reliable. So reliability isn't enough for validity, but it is required for validity. So it's kind of the first step, reliability. Once we establish we have that, okay, now let's look and see if we have validity. Are we being accurate in kind of measuring what we say we're measuring? Third key concept when it comes to assessment would be standardization. With this, we're talking about two things. One, standardization of procedures. So when you're gathering data in some assessment, and this could be if I have a questionnaire and I'm giving it to people, people are getting the same questionnaire every time. The questions are always in the same order. I'm not mixing it up. If I'm doing an interview, I'm going to standardize how I ask the questions, how I'm dressed, how I'm interacting with people, the setting that I'm doing it in. So it's all about doing things the same way across individuals. That way, if I see differences in individuals, it's not about, well, I did it differently this way. This time I was smiling when I asked the questions, and the other time I was kind of scowling. Well, that's going to affect their answers. We want to ask the questions the same way every time, have standardized procedures. That way, when there are differences in individuals, then it's more about them and not about what we did, right? The second piece to standardization is about getting that normative comparison group, right? A standardization sample. So you have some assessment and you give it to lots of people, thousands of people, until you can find out, okay, on this measure of aggression, on this measure of reading ability, on this measure of experience of obsessive thoughts, here's the average number of experiences people have. Here's the average score. And then also there's this kind of normal distribution, probably, some sort of distribution of scores where some people are above average, some people are below average, and you can figure out the exact percentages of people that are above or below different points, right? And because of that, now when I give you that test, I can say, okay, wow, you're way above average, you're way below average, you're right in the middle. I can tell where you are relative to this normative sample. So are you normal or abnormal in a very statistical sense? Okay. Why do we assess? Lots of reasons, right? One that's important for this class would be to determine a diagnosis, right? If you're going to go through this decision process, determine if somebody meets criteria, you need information with which to go through the process and make the decision. And assessment can certainly inform those diagnostic decisions. But they can also, assessment is also often used to make predictions and to make decisions. So think for a second about what kind of predictions you might make using a psychological assessment. What kind of decisions might be influenced by psychological assessment? In terms of predictions, often these things are used to predict how well we think somebody's going to do in a certain setting. Like, okay, we think you might be a good fit for this police force, right? But we need to know if you are going to be able to deal with long periods of boredom interrupted by periods of intense excitement and probably some fear, right? We want to be able to predict how you're going to respond to people challenging your authority. There's all these kind of important psychological functions that's important to be able to know what somebody's going to be like. So we want to gather data on police officer candidates to say, okay, yeah, based on these data, we think you would act this way. Okay, so then related to that, you'll make a decision. Yes, you can be an officer, or no, you actually would not make a good fit for an officer, or flight control, right? Those are all kinds of jobs where they're going to make decisions based on these predictions. Beyond that, think about medical procedures that involve psychological assessment. If you're going to get the bariatric surgery, right, and kind of those weight reduction surgeries where you get your stomach stapled, or the band, or whatever it is, oftentimes, if you're going to have those procedures, if you continue your current eating pattern, you'll get very sick and possibly cause great harm to yourself. So they want to try to figure out, okay, will you be able to reduce your caloric intake? Right? Can you change your diet when you start to get those sick symptoms, or will you eat yourself to death? Right? So there's psychological assessment involved to try to predict the outcome, and then used again to form the decision whether or not you're eligible to have that procedure done. A lot of people are interested in criminal profiling. Again, a lot of that is based on psychological assessment, gathering data to try to make predictions, and usually that's based on data that's been gathered before and patterns that have been identified. Other important decisions influenced by psych assessment, custody hearings, right? If you're going to get custody of your kids, if you're going to get visitation rights, oftentimes it's a judge that makes those decisions, but those decisions are often influenced by the testimony of psychologists, psychological experts that have performed assessments on the child, on the family, to try to determine what's best for the child. If you commit a crime, whether or not you're competent to stand trial, that's determined in part by psychological assessment. Even if you're competent to stand trial, let's say it's a capital murder trial, is the death penalty an option? Well, there's some states where it matters whether or not you have diminished capacity in terms of things like mental retardation, right? If you have diminished capacity, you're held less culpable, and then the death penalty is considered cruel and unusual punishment. Well, then it really may be a life or death situation, this kind of psychological assessment. So there's some fairly high stakes things. There's also fairly low stakes things, right? Where people are being assessed. Hey, I wonder what kind of personality I have. What color am I? And those silly surveys. Some of those based on good science, most of them not. But all kinds of predictions and decisions made with psychological assessment. And then relevant to abnormal psychology, of course, a lot of decisions are made in terms of planning treatment for people suffering from disorders or complaints that don't rise to the level of disorders using psychological assessment, right? Because it's not just, oh, here's your diagnosis. You have this diagnosis, this label. Okay, here's the treatment plan. It doesn't work like that, right? There's all kinds of variables that are important in terms of severity, the duration of symptoms, the surrounding factors, precipitating factors, setting events, family factors, all these things that are going to determine what's going to be the best treatment for you, most likely. Whether that help predict the likelihood of being successful in treatment. So all kinds of treatment planning decisions should be influenced by data gathered via psychological assessment. But it doesn't stop there, right? Once you have the treatment plan and you're doing the treatment, well, you keep assessing. You assess throughout, and including at the end, evaluating the effectiveness of the treatment. So is it working? If not, should we try something different? Okay. And once we're done, okay, was it successful? If so, maybe we should do this treatment again. If not, maybe it's time to tweak it. Right? Okay, when it comes to different methods of assessment, one of the big categories would be clinical interview. And one particular type of interview / observation that I think is worth talking a little bit more about is the mental status exam. And I'll talk a little bit more about it because it covers many of the areas of behavior that are assessed in psychological assessment. But this particular approach is it's broad but shallow, right? So you're trying to hit a lot of different key areas, but you're not going too deep in any of them. It's more of a screening, right? So things you're going to look at with a mental status exam include the individual's appearance and behavior. So in terms of behavior, their psychomotor functioning. If they're moving very slowly, and this includes talking slowly and moving their hands slowly. That's typically described as psychomotor retardation. right? And that can be associated with depression, can also be associated with some types of psychotic disorders with kind of catatonic features. Flip side of that would be psychomotor agitation, somebody who's real jittery and fidgety, moving really quick and fast, talking very fast, might be described as psychomotor agitation, so moving faster than normal. How they're dressed, right? So are they dressed normally and normal for their age, culture, geographic region, all those things, or are they kind of dressed atypically in a weird way? Are they dressed appropriately for the weather, right? If it's 20 degrees outside and they're in sandals and a swimsuit, that seems like abnormal behavior perhaps. This might indicate some cognitive impairment or delusions. Something's going on that's odd. Need to look into this further. Right? Of course, also that nonverbal behavior gets included in appearance. So one of the big things obviously being eye contact, right? So do they have appropriate or inappropriate eye contact? Eye contact overly intense, or more often lack of sustained eye contact, right? Downcast eyes, shifting their glance away while talking, or maybe while talking about particular topics. So all these things you're kind of taking note of. And there's not a form for this quite often. I mean, there is for the mini mental status exam, but generally this is something that you just kind of learn to assess these categories and take note of these things. Their thought processes, and obviously you can't see their thoughts. So what you're looking at here is their speech. So if they're talking very quickly, have kind of pressured speech, very fast, that may indicate racing thoughts. They're trying to get all this stuff out as quickly as they can, so their mind is racing. They have an accelerated thought process. That's worth noting. If they have tangential speech, so they're talking about one thing and then quickly shift to another and then another, and there's no thread weaving the things together. It's not clear that, oh, that reminds me of. No, they just switch topics. Okay, that may be indicating some kind of thought disorder related to kind of psychosis that's happening, or dementia, or maybe even delirium. Their mood and affect, right? So is it appropriate in terms of affect? Are they? Is it consistent with the content of their speech? So when they're talking about sad things, do they look sad? Talking about happy things, do they look happy? Or do they have kind of demonstrable affect where you can read their mood in their face? Or do they have kind of a flat affect that no matter what they're talking about, they just have this kind of blah face looking at you? Talking about mood, obviously, talking about sad or depressed mood. Flip of that would be a manic mood. If it's not depressed, not normal, but not quite manic, just kind of a little bit jazzed. The term we typically use is hypomanic, right? Hypo being under, so just under manic. And then for normal or typical mood, your $2 word would be euthymic. Oh, the client's mood was euthymic. Nice. You also try to get a rough estimate of their intellectual functioning. You gather this largely from vocabulary that they're using. So the range of vocabulary, the size of the words, the number of words in a sentence, or they're using kind of monosyllabic words, just 2 or 3 words in a sentence, or fairly complex sentence structure. Are they engaging in kind of abstract thought, using metaphors, or is everything very concrete? These kind of things to pay attention to. And then the last one would be the sensorium, right, which is your awareness of your surroundings. So this is the one when you hear people say, oh yeah, they're oriented ×3. Well, ×3 means they're oriented to person, place, and time. They know who they are, where they are, and when they are. So these are kind of broad categories that you should be able to get. Typically, while doing an interview in the back of your head, you're also gathering all this stuff, this other information. So when doing the interview itself, it varies in terms of how structured it is. So a fully structured interview, obviously you have, these are the questions you're going to ask, these are the order, and often they're kind of with branching logic, where ask this question. If they answer A, now ask this question. However, if they answer B, go down here and answer this question, right? And it kind of tells you where to go, and a robot could deliver the interview. You could probably have an app do it with kind of skip logic. A semi-structured interview, obviously there's certain questions you're going to answer you're going to ask. But once you ask the question and they answer, you can then follow up with, okay, well, how often did that happen? When did it first happen? That reminds me that something you said earlier. Tell me more about this, right? So you're not tied to, well, I've got to say this. A structured interview, you've got to stick to the script. Semi-structured, you've got a little more flexibility, right? So there's things you're definitely going to ask, and you have to ask to get through the whole thing, but you can kind of jump around and go deeper when you need to. And unstructured, obviously, you ask whatever you want. And I'd say that most of the things that are used clinically are unstructured and semi-structured, right? Because of the flexibility. I mean, rarely does a clinician go in with no idea what they want to ask. Typically, they know, they maybe have some notes. Okay, be sure to ask about their family, ask about this presenting problem, severity, duration, onset, all these types of things they're going to have either in their head or on paper somewhere. But they won't feel compelled to stick to it, especially if a client is particularly emotional and needs to talk about a particular thing. You know, you meet them where they're at and you let them talk about that thing. Okay. During the interview, obviously, you're gathering lots of content. They're saying lots of stuff, giving you information, and that's important. And you're going to be recording that, you know, either in writing or audio recording, video recording, making note of what's being said. But it's also valuable in the interview to attend to process, not just what they're saying, how are they saying it? And this kind of goes to some of the stuff going back to mental status exam in terms of their mood and all those observations you're doing, but also goes to kind of patterns, right? So let's say they start talking about, oh yeah, and my dog died last week and it was really hard, and well, I don't know, but anyway, I bought a new sweater, right? So as soon as they start talking something sad, maybe a little emotion creeps into their voice, and then boom, they're going to switch to a surface topic. And if they do that a couple times, okay, you know, I've got an idea here that this person has some discomfort with negative emotion or expression of negative emotion, perhaps, and their coping mechanism is to redirect conversation to surface level topics. That's going to be clinically important if you're going to be doing any kind of counseling or therapy with this person. Overall, pros and cons of interview method. Obviously, the pros, you can probe more or less in different areas depending on what they're giving you, especially if you have an unstructured or semi-structured interview. In addition to content, you get that process, that nonverbal information, and just generally lots and lots of rich information possible to get from a clinical interview. The flip side, the cons, to get that quality information, you've got to be a skilled interviewer. So the quality of info you get depends somewhat on the skill of the person asking the questions, right? And it's not something that's really easy, but it definitely is something that can be learned. And with more experience, you get better at it and more comfortable with it. It's also, whenever you're writing up the data, it typically comes out with some subjectivity, right? Because you're not going to write down everything they said. You're going to interpret it. Okay, well, they talked about how upset they were with their mother. And they may not have said they're upset with their mother, but you may have understood them that they were upset with their mother, if that makes sense. So there's a layer of your own lens that the information is coming through before it gets to paper, before it gets to a report. Some subjectivity gets injected. The individual may be unable or unwilling to give accurate information. In terms of unable, could be because of memory, if it's a long time ago, or maybe they had some dissociation. Maybe they just don't have the insight, right? If you're trying to figure out, okay, well, why do you think it is that you're always having these fights with your roommate? I don't know. And they really may not know. They're not lying to you. They just aren't aware. But there may be a reason, and it's a reason you're able to figure out together, but something that they can't tell you at that time because they lack the insight. Other times they may be unwilling to give accurate information, right? Or they don't. It's embarrassing or shameful, and they don't want to look bad to you. So they're going to make themselves look better than they really are. Or on the flip side, you know, maybe it's like kind of a workman's comp case or something, and they're wanting to look worse than they really are. So they're going to distort their report to you because there's some goal in line with some sort of secondary gain, which would be malingering, of course. Okay, in terms of behavioral observations. These can vary in terms of how formal they are. So if a very formal behavioral observation, you're looking for this specific behavior, and it might be something where in increments of every 5 minutes you're going to be watching for an hour, and every 5 minutes, did the behavior occur, yes or no? And you're putting a check, yes, it happened, okay. Wait for the next section, okay, nope, didn't happen in that 5 minutes. Next section, yes, right? And you maybe have a couple behaviors you're looking for. It can be very formalized like that, where you're looking for certain things in certain periods of time, or it can be more informal, right? Where you're like, okay, there's this kid that's been having trouble in school. I'm going to go observe them in the classroom. And you just go in and you sit in the back of the class and you watch what happens. And you know, so okay, yeah, that kid next to him is talking a lot and poking him with his elbow in the ribs, saying, hey, hey, hey. And then the teacher doesn't see that kid, but they see the kid you're there to see respond, and then he gets in trouble. Oh, okay, that's interesting. So that would be a very informal observation, right? You didn't know you were looking for that, but you're there and you discover it. Regardless of the formality, often behavioral observation involves kind of looking for this ABC pattern, right? Where there's some behavior of interest, there's something they're doing that's kind of a good behavior that maybe they're not doing enough, or more of a maladaptive negative behavior that they're doing too much that we maybe want to reduce. So we're looking for those behaviors to occur, and then we're looking to see, well, what happened right before? What's the antecedent? Which the idea being that, well, sometimes the antecedent may be causal to the behavior, or it just may be a signal. Okay, whenever this happens, we know this behavior might be coming soon. So whether or not it's causal from A to B, that may or may not be true. Also, whether or not it's signaling may or may not be true. But if there's a pattern, well, every time this behavior comes, this other thing happens, well, then it's definitely a signal, if not a cause. And then after the behavior, what happens? What's the consequence of the behavior? So is the behavior rewarded or punished? And usually it's not a simple single consequence. There's usually multiple consequences. Okay, when the kid did this in class, some other kids around him laughed. Okay, that was rewarding, but the teacher glared at him. Okay, that's a little bit of punishment. Right, so there's all these multiple reinforcement and punishment schedules influencing whether or not the behavior is going to occur again. And you're trying to capture all of that when doing an observation. But again, with the idea of thinking, okay, something's happening before, there's behavior, and then there's a consequence. And the big idea behind that is there's an assumption kind of inherent in behaviorism that behaviors all have functions. So you're doing this functional assessment of, well, what's the function of that behavior? Why are they talking in class? Why are they getting in fights? Why are they not talking in class? What's the function? What's rewarding? What's being reinforced about that behavior? What are they getting out of it? And if not, what are they getting out of it? What's the system around them getting out of it? Other classmates, the teacher, whoever. For some, that behavior is serving some function, and you're trying to figure out what that is. Symptom rating scales are often used to kind of look on the more formal end of behavioral observation. And this can be self-report, other report. Okay, how often do you do these things, right? So we're looking at for, let's say, eating disorders. How often do you, take laxatives? How often do you induce vomiting? How often do you exercise for more than 2 hours? All these things, looking for frequencies of particular behaviors that are thought to be symptoms or symptomatic of disorders. So there's those self-rating scales, also the other rating scales often used for kids. Think about like ADHD scales. Okay, how often is this kid up out of their seat? How often do they forget their homework? Right, all those things are behaviors they're asking somebody to not necessarily observe in the moment, but okay, think back over the last week. How often do you remember this kid doing these things? That would still be a form of behavioral observation. It can be helpful. Now, in terms of who's reporting, a lot of things that we're interested in, we get from self-monitoring and self-report. And that's either because the things we're interested in aren't observable by others because they're internal, right? So think about obsessive compulsive disorder, where you have intrusive thoughts, right? If I don't count to 10, my parents are going to die. That's an intrusive, unpleasant thought. Nobody can see you having that thought. So to know that you're having it and how often you're having it, when you're having it, you've got to tell somebody. So when gathering this data, you may assign somebody a self-monitoring assignment. And it's not just, okay, this week, how many times do you do it? It's, no, take this piece of paper with you all this week, and whenever you do that, write it down. Make note of it. right? Or at the end of the day, every day, maybe know how many times that happened, which can get good information. Interestingly, for a lot of disorder type behaviors, especially kind of habit behaviors like trichotillomania, people that pull their hair out and maybe eat it. Self-monitoring is good to assess the degree of trichotillomania. It's also a really effective intervention because if you can get people to attend to how often they're doing it, they do it less because it's kind of a mindless habit disorder. And as soon as you start paying attention to it, well, you don't want to do it, and you tend to decrease the frequency. That's kind of cool. So we do self-monitoring with self-report. We also get reports from others, especially with kids. And sometimes there's not congruency among those reports, right? So the kid will say, I'm fine, or, oh, everything's horrible. Teacher may say, kid's great in class, super attentive and nice and friendly. And parent says, oh, this kid's a monster. Okay, well, is somebody lying? Maybe. Might somebody be misunderstanding behaviors? Maybe. Might the kid be different in different situations? Maybe. These are all possibilities, and you don't necessarily know which one is true, but it is important information that they're not, if there's not congruency, well, that's important. If there is congruency, that's also important, but it is something you want to consider, and you don't just assume when you get a report from one person, especially about a kid, okay, that's how they are all the time everywhere, and it's 100% true. Maybe. Because again, it's not uncommon to have some incongruency, lack of agreement between reporters, because kids tend to figure out who they can do what things with. And again, if behaviors have functions, it may have a function in one setting and not have that same function in another setting. Overall, pros and cons of behavioral observation. Pros, you get some really detailed information potentially. You can get some unique information, especially in terms of self-monitoring, again, things that people aren't going to be able to observe. And again, either internal events or maybe shameful events, things like binge purging, right? You're not going to be telling your friends, hey, I just went to the bathroom and threw up. That typically doesn't happen. Typically, that's something people hide. If you're engaging in self-harm, cutting, again, something that's often hidden from others. So you're not going to know that it's happening or how often it happens unless the person self-monitors or self-reports how often it's happening. Flip side, in terms of the cons, there is the potential of reactivity, right? So whenever you observe behavior, if the person being observed knows they're being observed, they're gonna act differently to some degree, right? That's that reactive. They're gonna react to the situation of being observed. And so what you're seeing may not be the true behavior, which is why if you ever do work with kids and you go do a classroom observation, you got to stay a while, and you may have to come back another day because they may put on a show for a while, even for a whole day, depending on what's going on with that kid. But typically they can't keep it up forever, and so if you can observe long enough, you'll get past that reactivity and get a truer picture of what behaviors are maybe problematic. Again, some observation is difficult to get. If they're not able to self-monitor, not willing to report honestly, it's really hard to see some things. And then obviously, if you're getting reports from others, even from the individual, sometimes those reports are biased. They're not reporting the truth for a variety of reasons. Okay, moving on to personality inventories. So these are standardized self-descriptions with normative comparisons. Right? So when I talk about standardized, you're getting these are typically paper and pencil, pen and paper, or more recently computerized or tablet-based assessments. People are getting the same questions in the same order all the time. It's not random. It's very standardized in terms of the procedure. And also, these are inventories that lots of people have taken in the past before it's ever given to the public, so they know, okay, here's the average score on these questions, and if you get this many points above that score, that's really rare, right? That's 1, 2, 3 situations above the mean, below the mean, whatever. You can do those normative comparisons. So even though they're called personality inventories, they don't typically just measure personality. They quite frequently also measure aspects of psychopathology in terms of psychotic symptoms, eating disorder type symptoms, anxiety, all these things that are more than just what we'd consider personality or personality theory type things. A lot of these inventories have different normative groups you can compare to, right? So when you take this inventory, often you may have a community normative group. Okay, so how do your scores compare to Joe Schmo off the street? And that may be important. So, wow, you're at 70T, so 2 standard deviations above the mean on this measure of depression compared to the community norm. But then we say, okay, well, let's look at this other normative group, people who are presenting to a counseling center with concerns about depression. Okay, compared to in that comparison group, you're at 50T. Oh, you're right in the middle of the average. Okay, so yeah, you're depressed, and more depressed than the typical person, but you're not more depressed than the typical person presenting for therapy. If you are, in that case, you'll probably be like 80 or 90T on the community one, and then 65, 70 on the clinical comparison group. Well, then that's more significant, more severe, and either you're exaggerating your symptoms, either maybe malingering, maybe a cry for help, or you're really, really depressed, and we should be very concerned about your well-being, right? So having these different normative groups is helpful, and depending on what situation you're looking at. Most of these measures have some validity scales, right? So they've got questions built in to determine if you're answering consistently, right? So they're going to ask the same type of question over and over again. And if you answer them differently, well, that shows you're not paying attention, or maybe you have thought disorder. But if you have inconsistent answering, it's going to show up on a validity scale saying, oh, the results may not be valid, right? There are also usually questions in there to try to identify people that are trying to look better than they are, doing positive impression management. Whenever somebody asks me to contribute to a charity, I do every time. Very true of me always. Well, probably not, right? Because if you're saying yes to that, you're probably faking good. You're probably trying to come across as a better adjusted somehow person than you are. And there are a variety of reasons why people want to engage in positive impression management. On the flip side, some people might want to be engaging in negative impression management, trying to look worse than they are. Again, either for some kind of secondary gain, malingering reasons, or because maybe they really are struggling with something, anxious, depressed, whatever, and they want to make sure you know it. It's kind of, hey, yeah, really, a lot. And it's not as much as they're saying, but they just want to make sure that they're going to get some help, and they're worried that if they don't kind of exaggerate a bit, they're not going to get the help they're looking for. The 2 most common inventories right now are the MMPI, the Minnesota Multiphasic Personality Inventory, and the PAI, Personality Assessment Inventory. The book talks a bit about MMPI and how it was created. Partially because of how it was created, I prefer the PAI, because the MMPI was created with this kind of discrimination model where you have these groups of people that have a diagnosis and those that don't. And if a question can discriminate between the groups, okay, so everybody with schizophrenia, they answer true to this question. People without schizophrenia, most of them say false. Okay, then that question goes on the schizophrenia scale, regardless of whether or not that question has anything to do with schizophrenia, right? If that question is, how much do you like Mickey Mouse? And there's some weird quirk of statistics where this group of people with schizophrenia all said yes, and most people who didn't said no. Okay, now if you say yes, that's going to load on the schizophrenia scale. Well, just from a test construction standpoint, that's not very good, right? The questions should have be related to the construct that they're measuring, in my opinion, and that's more of how the PAI was built. So, personal preference, that's my preferred method. But both have a lot of research supporting them. The MMPI has been around longer, so it has more research about what the scores mean, but both usable measures. Excuse me. In terms of pros and cons, pros, with these things, you get a wide range of behavior. Of course, you're usually asking, more than 200 questions of these folks. But because you're doing that, you're gonna hit lots of different categories. Like every disorder in the DSM, you're gonna have some questions in these inventories about each disorder. You get that actuarial interpretation with T-scores, right? Because you have normative groups you're comparing to, so you can talk about how rare somebody's responses are. Wow, this person is really depressed, or wow, they're looking like they're really not depressed, which is weird in of itself. You should be kind of in the middle. And the validity scales is a good feature. So you can determine if somebody's, answering randomly or trying to look bad or trying to look good. Flip side, the cons, the quality of data you can get from these things depends somewhat on the cognitive ability of the person taking the test, right? Are they able to read and understand the language? And again, if the test is in English and English isn't the primary language, that could lead to some misunderstandings and answering questions in kind of a weird, idiosyncratic way. Or if they have any kind of cognitive deficits, they don't understand the questions, they may still answer true or 3, I don't know. That can take away from the validity. Or if they have, kind of some psychotic features with thought disorder, they may not be able to concentrate, or kind of ADHD stuff, concentrate long enough, because these things are pretty long. And the other thing is, the validity scales are great, but if those scales come back and it says, oh, it's not a valid measure, they were inconsistent, or oh, they were faking, well, now what? I just wasted 2 hours of their time and a certain amount of money, and I don't have any good information other than, yep, I know they tried to fake. That's weird. I wonder why. Which is some information, but it's not the information you were probably looking for. Okay, moving on to projectives, fun stuff. So with projective tests, clients are asked to respond to some ambiguous stimuli. This being an example of one of the more well-known ones. And so you present somebody with a series of cards and you say, here's a picture. Tell me what you see. And they would tell you something and you'd write everything down. Anything else? Anything else? Right? And they're going to say a bunch of stuff, right? So that, of course, is from the Rorschach ink blot test, right? Which for a long time people were like, oh, yeah, this Rorschach, people just, who knows what it means when you say you see this or see that? You're just making it up. And to some degree, people probably were. They tried to standardize a bit more. Exner came up with a scoring system, which is fairly comprehensive. And it's not maybe what you think it would. So there are some pieces of it where you're looking at the content of the response in terms of, oh, did they see animals? Did they see blood? Did they see people? Did they see supernatural things? That goes into the scoring system. That's a small piece. A whole bunch of the rest of it is, okay, did they use the white space? Did they use shading? Did they use color? Did they see motion? Did they use the whole blot or part of the blot? And all those things go into scoring different subscales, which you have to add up via this fairly complex scoring procedure to come up with some hypotheses about what it means. So there's some attempts to standardize the application, but I'd say things like the Rorschach not used much these days. And when they are, I don't think people are using Exner too much. They're more just kind of using it. Oh, it'd be interesting to see what people say, and then coming up with hypotheses about what it means without a really kind of systematic approach to it. Here's another stimulus from a different test, right? This is one where you get a series of cards and you'd say, okay, tell me a story. Tell me a story with a beginning, a middle, and an end. So this is from the thematic apperception test. So obviously you're looking for different themes that appear in the story. And again, this is something where there is a scoring system where you're looking for different things and different presses. But a lot of people don't use the scoring system. They just kind of look for, okay, well, did they have a bunch of violence? Was it always about mother-son relationships, right? There's all kinds of psychodynamic Freudian stuff usually associated with projective tests. In terms of pros and cons, one of the big pros is these are really hard to fake, right? How do you fake good on the Rorschach? What's the right answer? There isn't a right answer. Nobody knows. So that's good. One of the other helpful things is not so much necessarily the content of what you're getting of what they're saying, but the process, right? So are they open to and willing to, say things? Oh, I think that it's like this. Or do they seem more hesitant and worried about you judging what they're going to say? When they're telling a story in the thematic apperception test, do they get emotional in some parts? Do they get quiet? Do they get angry, right? Are they having an emotional experience related to the stimuli? That's interesting, important information that you can sometimes get. Obviously, the big cons would be reliability and validity. If you're not using a standardized scoring system, which many people don't, then it's not clear what the data mean, and there's a lot of subjectivity that gets injected. And of course, to do these well, it takes a lot of time. And taking a lot of time from a psychologist, that's the people that are kind of allowed to do projectives, it's also going to be expensive for the client. So helpful in a limited sense, usually more for kind of in a clinical sense, helping people get to talking, kind of break through that inertia of silence with these projective techniques. More helpful for that than for actually gathering data in terms of psychological assessment. Okay, intelligence tests. These are for measures of cognitive abilities, right? And it's more than a single IQ score. They're really moving away from, okay, well, what's your IQ? When you give an intelligence test, you don't really care what that IQ is. You can still generate a full-scale IQ score, but there's all kinds of little subscale scores for different cognitive abilities that are much more interesting in looking at the pattern of what's high and what's low for an individual. And this is something that can be helpful in terms of psychopathology, mostly in terms of things where you're looking at possible memory impairment with dementia or possibly dissociative disorders. From a clinical perspective. From just a research perspective, there are some interesting questions here about, okay, when people are experiencing depression, how do their cognitive abilities, how are they different than when they're not depressed, right? Those things aren't used clinically, like to diagnose or anything, but there are some interesting research questions about the data that can be gathered with intelligence tests. The most common ones would be the Wechsler test, the WISC, and the WAIS. The WISC being the Wechsler test for kids. The WAIS is the one for the adults. And the WJ is the Woodcock-Johnson, which is kind of an alternative to the WISC. These are obviously typically standardized tests, right? So given the same way every time, there's lots of rules. Whenever you're administering these tests, you're going to tell people, okay, I want you to draw a picture. The picture should, right? You've got a script that you've either got to memorize or read from a book, and you should do it the same way every time. And oftentimes there's even rules about how quickly or how slowly you're saying certain words so that the answers aren't influenced by the method of administration because it's been standardized. And of course it's also normed, and these norms are typically age-based. So your scores aren't being compared to people, they're being compared to people your age within a range of 5-10 years, with a smaller range obviously for kiddos. Pros and cons, heavily researched, lots of data on what these scores mean. So they don't always mean what the test originator thought they would mean. Okay, here's this measure that's going to measure verbal fluency. Well, it turns out it doesn't measure verbal fluency, but we know it measures this because of all these other studies indicating kind of what it's associated with. Obviously, you get more than just that one IQ score. You get this pattern of abilities with these things, especially the newer ones. In terms of cons, there's certainly the potential for misinterpretation, right? Especially if you give too much credence, emphasis to that full scale score. Oh, I'm highly intelligent or not intelligent. These are measures of one type of intelligence, and it's well accepted in our psychological community that there are multiple types of intelligence, and that the type of intelligence measured by these tests is pretty specific to a type of intelligence that is useful for being successful in an academic setting in a westernized culture, but not much beyond. The people that are kind of smart, right, able to problem solve and figure things out at a very high level, that don't do well on these tests, and they also don't do well in school. So limited to what it means, but the other thing is the normative comparison group may or may not be appropriate, depending, especially if you have somebody from a unique population, right? You've got a 6-year-old whose parents are first generation Americans immigrated from Vietnam. Vietnamese spoke exclusively in the home till the child was 4, and now you're going to compare this kid's scores on verbal fluency in this test in English, and he's only been exposed to English for 2 years. okay, that may not give you a really good idea of how intelligent this kid is, right? So there are some limitations to interpretation. Okay, looking at physical markers, talking about a couple things. One, psychophysiological assessment, right? And this is primarily where we're measuring indicators from the autonomic nervous system. Remember, it's part of the peripheral nervous system. You've got the somatic and autonomic, somatic being muscles and all that, autonomic being your automatic things, respiration, perspiration, heart rate, yada yada. And we've got things we measure kind of outside the brain, GSR being galvanic skin response, heart rate, respiration, right? So these are parts of or phenomenon, physical things that are due to signals being sent from the brain, but we're not measuring up in the brain. And then we also have at least one thing we can measure in the brain here. We took a look at EEG. We're looking at brainwave activity. So when we measure these things, there's some assumptions we make that these phenomenon, like how much you're sweating for galvanic skin response, how quickly your heart rate is beating, that is a physical manifestation of a psychological process, right? Okay, your heart rate is high because you're anxious, right? That we can see how anxious you are because we see your heart rate being high. Now, the degree to which that is true depends, right? If your heart rate is high, well, you might be anxious. You might also be angry. You might also be excited, right? So there's not a whole lot of specificity with these markers, especially the ones that are outside the brain. Once we go inside the brain, look at EEG, it's possible we can get a little more specificity. And this is still a pretty new area of research where they're trying to map EEG patterns and where they get people to, think about a certain thing, focus on a particular emotion or sensation, and then look at the EEG pattern and then work backwards from that to say, okay, well, when we see this pattern, it means this. And maybe someday they'll get to be able to read that, or they can read your thoughts with EEG. But obviously not yet. That's still down the road. Also, it's often important for somebody that might have a psychological disorder that's having psychological concerns to get a physical examination, and something they would obviously get from a physician. And the things we're often looking at related to psychological functioning often relate back to the endocrine system, right? So things like the thyroid involved, hyperthyroidism, hypothyroidism, that can be related to anxiety and depression. We have kind of hormonal imbalances due to that system, or a tumor somewhere can manifest with kind of psychological symptoms, mood symptoms in particular. The other thing we often want screened in physical exams is substance use. So if people are exhibiting abnormal behavior, maybe they're high, maybe they're on withdrawal. Okay. Neuropsych testing and imaging. The neuropsych testing, so you're getting this battery of tests. Usually you're in for a good couple of hours where they're asking you to do things, right? You have some maybe written tests. You may have where they're going to say, okay, I'm going to tell you some numbers. I want you to repeat them back to me backwards. Okay, now repeat them back to me forwards. Okay, here are these cards. I want you to sort them by color. As you're sorting by color, okay, now sort them by shape. Okay, now sort them by number, right? And you're seeing if people can switch from one task to the other. And you're doing all these things, having them perform these cognitive and behavioral tasks to look to see if they have any deficits, things that they can't do as well as the typical person, right? Because again, you've standardized how many things people should get right for people that are neurotypical, people that don't have any brain damage that we know of, how well they do. And then we're having these people do these things. And they've administered these tests enough to people that have documented brain damage. Okay, we know this person has a lesion here. This person has a tumor in this area. This person had surgery and this part of the brain is gone. Okay, how do they do on these tests? And you begin to map out relationships between test performance and damage to different areas of the brain. So these correlations between these deficits and dysfunction or damage to the brain, which can be really helpful. And again, it's not to the point where you do neuropsych testing, okay, well, you clearly have a tumor in your amygdala, sorry, but it is, hey, there may be a problem in this area of the brain. Now let's go to the next step, and the next step being often brain imaging. And the testing, even though it's fairly time intensive and not cheap, it's still usually cheaper than imaging. And also it can kind of narrow the focus. Okay, well, left hemisphere seems fine, but you may have some right hemisphere problems. That's where they should focus their scans. That's where the radiologist should be looking when they're looking at your scans. Okay, in terms of the scans, looking at two things typically. One, looking at the structure of the brain. So again, looking often for tumors or defects, deformities, changes in the vasculature. So looking at CAT scan, MRI. More interesting, I would think, is the imaging things that we can now do looking at the function of the brain with PET scans and functional MRI. We were taking several pictures like a little movie to look at brain activity. And again, it's not just usually, hey, let's look at your brain. Typically, you have to be injected with a radioactive dye first, and we're looking at basically glucose activity in the brain or oxygen activity in the brain, which is pretty cool stuff. And maybe someday will be helpful in diagnosis. It's not there yet, right? But there's certainly some correlative data where we say, okay, wow, people that have this disorder have a lot of activity in this part of the brain or less activity in this part of the brain. But it's not, that correlation isn't so high. It's not a 1.0 correlation where, okay, everybody who has that high activity has that disorder. Nor does everybody who have the disorder have that high activity. There's enough exceptions that it can't be used diagnostically. But that may also be related to fuzzy diagnostic categories, which we'll talk about in a bit. Okay. Last method is simply looking at existing client records, right? So looking over their health records. Do they have history of thyroid problems? Do they have history of heart disease? Do they frequently present to the doctor with a variety of medical complaints? We're looking kind of hypochondriasis maybe. Educational record, right? So not just how educated are they, but how have they done? Were they doing really great and then the wheels fell off at some point in high school or college? They have this kind of up and down pattern of academic success that maybe suggest some sort of episodic disorder. Employment history, is it stable, or have they gone from job to job? They can't hold a job down. Have they advanced in their career? And these are all things that are helpful in terms of looking at impairment, but also may signal some sort of pattern. Criminal history, to what degree are they able to adhere to the societal values and boundaries that keep you out of jail? If they can't, maybe there's some psychological disorder associated with that, maybe impulse control, maybe it's a cognitive deficit, maybe it's personality disorder, or maybe it's just environmental. I was poor, I wanted to eat, so I stole something, right? But again, these are sources of information to create hypotheses. Obviously, of course, you also want their records if they were ever previously in treatment or previously assessed. Don't want to reinvent the wheel, so find out what you can already know about a client before starting to gather more data. Okay, in terms of level assessment, typically we think about assessing at the individual level. So this person's coming in, they have these issues, let's find out about this person. But sometimes the level of assessment is at the couple level or the family level, right? Where the individual isn't the client, the couple is the client, or the family is the client. And when that's the case, for a couple, for example, when the couple is the client, it's not just two individuals. It really is a couple. So you want to know about their relationship. And that's different than, oh, I want to know about this one and about this one. Well, no, I want to know about your relationship together. So in doing that, I can also be looking at the relation between individual characteristics. So I'll look at the couple, also look at, okay, wow, you're really aggressive and you're really passive. Okay, I see a pattern there. I can look at the attributions that different members of a family system or a couple make regarding the behavior of other members of the system. As we've already alluded to, we can identify these kind of relational patterns, right? The most common one being that approach avoidance, right? Where one person wants to say, hey, I want to talk about it. And the other says, no, I don't want to talk about it. and they pull away, and when they pull away, the person goes forward. When they go forward, they pull away, and they're chasing each other around and around the tree, right? But you might also need to look beyond that. Whether you're working with an individual or working with a couple or family, you may also want to consider environmental and cultural aspects that are playing into whether or not their behavior is pathological or whether it's not pathological, and then also what to do about it. You know, there's some culturally relevant things that may need to be considered. Okay, moving on to diagnosis. Where do the diagnostic labels come from? Well, in the U.S. started roughly 1840 with the census, and there was a need to classify individuals with different problems, right? And this was largely from a government point of view, where you've got some people that have these difficulties, and it was at that time largely looking at things like mental retardation, that it didn't use that term then, and they needed to know, well, how many people have these issues, and where are the people with these issues, because we need to know where to direct our resources. You know, where should we put this, you know, hospital or school or clinic? You have to gather that data in the census to know where to direct the resources. And obviously you have the development of the DSM, the Diagnostic and Statistical Manual of Mental Disorders, written by the American Psychiatric Association, influenced heavily by Emil Kaplan's work on classification. You have it from volume 1, the first version is called the DSM, to what we have now, DSM-5, growing quite a bit. The first version had 106 disorders. We're now up to, I think, 297, so tripled in number of disorders. So does that mean that back in the day there weren't as many, people weren't having as many problems? Maybe, but probably more so we weren't dividing things up as precisely, right? Now we're cutting things a finer shade, right? Back then, okay, oh, this person has neuroses, they're neurotic. Well, now, okay, well, neurotic, that means anxiety, so maybe they have generalized anxiety disorder, maybe it's OCD, maybe it's PTSD, maybe it's reactive attachment disorder. All these different things now that we're differentiating between would have gone in one bigger category back then. Now we're looking at the process of creating the labels. It comes from developing a nosology. A nosology being a classification system for psychological phenomenon. And there's a couple of approaches to nosology that have influenced the DSM over time. One being the classical approach, and this is where you have you assume that every diagnosis has a single cause, and one set of conditions or symptoms is necessary and sufficient for diagnosis. Right? So if someone's going to be diagnosed with depression, they have to have sadness, loss of appetite, and decreased energy. They've got to have all three of those. If they have those three, they have depression. The problem is some people have increase in appetite instead of loss of appetite, and not everybody has a decrease in energy. Not everybody's even sad. Some people, instead of being sad, they have anhedonia, like loss of interest in pleasurable events. So the classical categorical approach didn't really work out too well for us. The dimensional approach, two ways of doing this. One would be where category membership, so assigning people into a category, into a diagnostic label, depends on how much of a given symptom or set of symptoms that person shows. Okay, so it's like, imagine that kind of green light to red light. Okay, no symptoms, green, yellow, getting closer, more symptoms, bing. Okay, now you have this many symptoms. Yep, you meet criteria. Another way to look at it would be to not have categories at all, but just have dimensions or a series of dimensions that people could be ranked on. So how anxious are you? How depressed are you? How much do you have abnormal perceptual experiences? You know, think about hallucinations. And the current DSM, as we'll see, has moved closer to including some dimensional thinking, but we're still not at a dimensional approach. What we're really at is this kind of prototypical approach. And this is one where there are thought to be essential characteristics for group membership that are necessary but not sufficient. And other characteristics that are typical of some prototype exist, and if you have enough similarity to the prototype, then you're in the category, right? So with depression, the essential features, essential characteristics are either depressed mood or anhedonia. You have to have one of those two. And then you've got to have, a couple of these other things. You can have lost appetite, increased appetite, crying, guilty feelings, and then you're going to set how many of those things you have to say you're similar enough to a prototype and fit in that category. Okay. Once you develop this classification system using this nosology, there are some issues in applying it, right? And this kind of goes back to what we talked about in terms of assessment, right? So we talk about the reliability of a classification approach, classification system, something about like the DSM. How reliable is this diagnostic category? So if you have somebody presenting with some symptoms, let's say there's a video of them talking, or there's a case report talking about their experiences, and you've got 5 different clinicians, reading that report, watching that video, interviewing that client. Are they all going to agree on the client's diagnosis? Because they're all using the same classification system. They're all using the DSM. And if they all agree, then you've got good reliability in classification. Unfortunately, you don't always agree. And how much you have that inter-rater reliability, that agreement across clinicians, it varies significantly across disorders. Some have greater reliability than others. Also, in terms of reliability across time, and again, depends on the disorder. If it's something that is conceptually chronic or not, whether or not it should be continuous across time. Also, kind of going back to those ideas we talked about in terms of assessment, validity is important. So the construct validity of a diagnostic category. So think about divergent construct validity. If you meet criteria for depression, then you shouldn't necessarily always meet criteria for generalized anxiety disorder, right? If every person diagnosed with depression also gets diagnosed with generalized anxiety disorder, those aren't the same disorder. So you shouldn't have 100% concordance. If you do, you've got poor divergent validity. Right? They shouldn't be exactly the same. They should diverge some. You can also look at criterion validity. So, does knowing something about your diagnostic label, the category you're in, tell us something meaningful about outcomes, course of the disorder, potential response to treatment? And again, there's a lot of variability across diagnoses, the degree to which you have that criterion validity. Some have more, some have less. Why do we diagnose? Really, it's about communication, right? Communication amongst providers, mental health providers, amongst researchers, and then also with clients, right? So these diagnostic labels are arguably simplifications of complex phenomenon, right? If somebody's experiencing major depressive disorder, that means that, again, they're having depressed mood or anhedonia and like these 5 other symptoms, and they're having these periods of these mood symptoms in intense depressed mood, for example, for for a minimum of 2 weeks, and then outside of that 2 weeks, some symptoms, some level of those symptoms remain, and the symptoms cause clinically significant impairment, right? So rather than saying all that, I can say, oh yeah, they meet criteria for major depressive disorder. And somebody who knows what that is knows generally what's going on. Difficulty with that, obviously, is you've got some heterogeneity in that group of people diagnosed with depression, right? Because you have in there, for criteria, you've got changes in appetite, changes in sleep, but it's not always in the same direction. You could have somebody who's depressed who has an increased appetite and increased sleep. You got somebody else depressed who has decrease in appetite and decreased need for sleep. Opposite presentations both get the same category, right? So it's used to communicate, but it's important to acknowledge that it's a somewhat crude form of communication. That diagnostic label isn't enough. It's a good starting point. Oh, okay, Dealing with depression, gotcha. It's not schizophrenia, it's not eating disorder, it's depression. Okay, cool. We'll start there. That narrows the field down for what we need to talk about with this person in terms of treatment or for research. And also for clients, it's a mixed bag, I'd say, for clients. Right? Sometimes it can be helpful to have a label. Oh, PTSD, that's what I have. I thought I was crazy. But no, this is this disorder that other people have. It's a traumatic thing, and my brain's responding this way, and it's a pattern that other people have. Okay, and there's treatment, there's something we can do about it. Awesome, I feel way better, right? In that sense, the labels are often helpful. Sometimes the labels are less helpful, right? Especially if they're kind of more if those labels have some negative connotation to them. Say, oh, I have that. And if that becomes a big part of the identity, well, I wish I could help, but I've got depression. Sorry. And maybe they're not depressed at that moment, but they begin to see themselves, no matter what happens, oh, that's because I'm depressed. Oh, that's because I have OCD. Well, maybe it's not because of that. Maybe there's some other reason. But it's pretty easy for that to become a huge part of who you are, just like any other label we apply to ourselves, even the silly ones like if you're a Bengals fan. Oh, that's because I'm a Bengals fan. Not really. Also, we diagnose for reimbursement to get paid, right? Oftentimes, insurance companies, they don't want to be paying clinicians just to talk to people, right? You've got to have an identified problem, some disorder that needs therapy, because God forbid people go talk to somebody and get help unless they can check a box. But that's where we're at, is a lot of times to get reimbursed by an insurance company, by a third-party payer, the people you're seeing need to meet criteria for some disorder, which obviously that introduces some ethical issues in terms of you're incentivizing pathologizing people. So if somebody's kind of on the border, they maybe meet criteria. Well, if I want to get paid, they need to meet criteria. Okay, that could happen, maybe. Okay, our current system. So we're with the DSM-5, right? And it's changed from the DSM-4. Those of you who maybe have some exposure to that, because it's fairly recent. Remove the multi-axial format, right, where you had axes 1 through 4, with the big thing being axis 1 were your major disorders, axis 2 being personality disorders and mental retardation. Did away with that because they said, well, you're kind of making it look like, well, axis 1 is clearly more important than axis 2, and people didn't like that. So the information that was there before in all those axes is still reported, just not in axial format. It's not kind of rank ordered. One of the other big changes is the addition of dimensional ratings of different components of psychological functioning, right? So it's not the degree to which you have schizophrenia. It's not that. It's still, you have this label, you don't have this label. So that part is still there. But there's some psychological functioning variables like the degree to which you have impaired sleep, the degree to which you're experiencing anxiety, that clinicians now can rate people on, which is very helpful because these are phenomena that cut across disorders, and it may be more helpful in terms of treatment. Okay, what do we need to focus on? Oh, I've got this label. Yeah, but what's the problem? Oh, you're not sleeping? Okay, then we need to talk about some sleep hygiene stuff, right? Excuse me. So that's one good thing. Another good thing, potentially, is the option here to create a cultural formulation. So there's a space in there where you should identify how cultural, environmental factors influence maybe the formation, maintenance of disorder, or treatment of the disorder. And that's potentially a good thing as long as it's not misused, where members of a majority culture use somebody who's a member of a minority culture uses that to over-pathologize. Oh, well, clearly it's because of this. Well, maybe it's not a cultural thing. Maybe it really is this other psychopathological thing. But if there's kind of prejudice that creeps in, you can kind of, oh, it's because they're in this group, and that's how they are, right? If you get those kind of stereotypes applied, that can be dangerous. In terms of criticisms of the DSM, these are kind of old criticisms that still stick around. I alluded to this one earlier. There's still some fuzzy categories, right? Where there's symptom overlap, where if you have, oh, okay, I've got difficulty concentrating. Well, that could be depression, that could be PTSD, that could be dementia, that could be, the same symptom occurs in lots of different disorders. which makes them not very clean disorders, right? Well, do you really have that, or do you have sort of a mix of these two? Are you somewhere in the middle? Are these things really separate things? Because we've arbitrarily somewhat drawn the lines around this is disorder, that's disorder, and they're different things. Right? There's no blood test to say, oh, this is diabetes and that's cancer. It doesn't work like that. These are just constructs that we've decided this is depression, that's OCD. Right? Partly because you have these fuzzy categories, you've got some fairly high rates of comorbidity, people being diagnosed with more than one disorder. And once you're diagnosed with one disorder, the odds of being diagnosed with the second go up. Once you're diagnosed with two, the odds of being diagnosed with a third go up, which is kind of like, well, what does that mean? Does that mean that when people have difficulties, they are global difficulties that will show up in lots of different ways? Or does that mean, again, our categories aren't that good and people are just having some life difficulties and we can't put them clearly in a box as maybe as much as we'd want to. And as I've already indicated, there's significant heterogeneity within categories. Not everybody with major depressive disorder looks the same. In fact, they look quite different. Bipolar disorder, very heterogeneous group. Just because you know somebody, maybe you know one person with bipolar disorder, oh, I know what that's like. I know someone. If you know 2 people, you know 20 people. That means you know 20 people. You don't know everybody with that disorder because, again, it can present very differently across individuals. Okay, moving on to the last few things here. Basic components of a research study. Obviously, you're going to have variables. And if you're doing an experimental study, you're going to have an independent variable and a dependent variable. The independent variable being the one that the researcher manipulates, right? I'm going to assign you to this group or that group, right? Drug or placebo, watch the scary movie or watch the funny movie. So type of movie, independent variable. Amount of drug, independent variable. Now, whenever I think that putting you in this group or that group, whatever is going to be done to those different groups, I think that's going to affect you in different ways on some other variable, right? Okay, this drug is going to, more of the drug or less drug is going to make you more sleepy. Okay, how sleepy you are, the thing that's going to be affected by the independent variable, that's the dependent variable, right? Because I think that it will depend on how sleepy you are, depends on the level of the independent variable that you received. Okay? You know, watch the scary movie or funny movie. How much you laugh will depend on what type of movie you saw. So how much you laugh is the dependent variable. Okay, so that's for experimental study. If you're in a correlational study, the kind of comparison would be instead of, we don't use independent, dependent variable anymore. Now we use the terms predictor and criterion. And predictor is kind of like the independent. Criterion is kind of like the dependent. That's why I put them together. But basically, the predictor is, okay, if I measure this one thing, and I think it's related to this other one, the thing you're measuring and thinking about first is the predictor. Okay, if I know how much anger you have, can I predict how many friends you have, right? So how much anger you have is predictor, how many friends you have is criterion. And again, which one's predictor, which is criterion is somewhat arbitrary, right? Because with that same example, you could flip it. I think not having friends would make you angry. So if I know how many friends you have, can I predict how angry you are? Okay, well now number of friends is predictor and how angry you are is criterion. So it really is about conceptually which one you think is kind of coming first. All research studies should have hypotheses, and they should be hypotheses that are testable and falsifiable. Right? It's not just an educated guess. It's it's a prediction about the outcome of the study. Right? So that prediction should be testable. So the thing you think, I think this is going to happen, you should be able to test whether or not it happens. An example of something that's not testable, say I've got this psychotherapy. I think using this therapy, it's going to be effective because it realigns people's chakras. Okay, well there's no kind of scientific way of measuring chakra realignment, and so that's not a testable hypothesis. Now maybe it does do that, I don't know, but I can't test it, therefore it's not a scientific question. Hypothesis also has to be falsifiable. It has to be possible to be wrong, right? Say, okay, I think this treatment for aggression will be effective. And you do the treatment, and if everybody stays in treatment and says, yeah, it worked, then I'll say, yep, it clearly worked. Now, if people drop out of the study, everybody drops out and they go, okay, well, it clearly worked because they no longer felt they needed to come. Okay, so no matter what happened, you were going to say it worked. Well, then it's not a falsifiable hypothesis, right? You got to set up in such a way that you can test it, and set up in such a way that there's an outcome where you could be wrong. Excuse me. In terms of research design, this is kind of the plan for how you're going to do research. We'll talk more about different designs in a minute, but just broadly, we talk usually about experimental versus correlational being the two major categories of research designs. And when we're focusing on experimental research, we talk a lot about internal and external validity. Internal validity being internal to the study you're doing, with these people in this time, in this setting, with these variables, with these measures, these stimuli. Internal to this study, whenever I find a cause and effect relationship, because that's what experiments are about, how confident am I that the effect on the dependent variable, the change, the difference in the dV, was caused by the independent variable. If I have high confidence that I've got good internal validity, I've done things to protect my internal validity, yep, then I'm very confident that this difference, this change is because of what I did. External validity is whatever that truth is that you found in this study, to what degree can you generalize that truth outside of the study to people that are not like people in your study, to situations that are different than the ones studied exactly in your study, right? So if I did the funny movie, scary movie, how much do you laugh? Okay, well, I only showed 2 movies, right? I showed Hook and Friday the 13th. Okay, well, what about The Ring versus Jackass? Am I going to see the same difference with those movies? I don't know. It depends on the external validity of the study. How far can the findings generalize? So some things that will affect the validity of the study, primarily internal validity, are whether or not there's a confound, right? So when we look about experimental studies, the simplest version would be when you have 2 groups, experimental and control, and the only thing that should be different between those 2 groups is the independent variable, right? You got the drug, you got placebo. Otherwise, you're treated exactly the same. Same time of day, same room, same investigator interacting with you, all these things. Now, if anything else is different across groups, okay, so you got this group got the drug, this group didn't. The group that got the drug also had an experimenter that was smiling. The group that didn't get the drug got an experimenter that was scowling. Okay, well that's a variable that differs systematically across levels of the IV, and it may affect the DV. If it does, well now I see a difference in the DV. I can't be confident it was because of what I did. Maybe it's not because of the drug. Maybe it's because of the smiling and the scowling. That difference is a confound variable, or in short, a confound. So if I want good internal validity, I've got to make sure I eliminate all confounds. Obviously, I've got to have a control group and an experimental group, and have at least 2 groups. I've got to have the power to randomly assign people to group. And this isn't random selection, random sampling. This is random assignment. And random assignment matters only because it's thought to lead to equivalent groups. It may not. You may randomly get very different groups. But if you're doing things randomly, then you should get groups that are roughly equivalent in average age, average intelligence, average level of depression, whatever, because you've randomly assigned them. And then you also, to have good internal validity, you have to exert experimental control. And that's those things about eliminating confounds, doing things the same across groups, and keeping outside variables from affecting scores on the dependent variable. Okay, issues in clinical research. Statistical significance versus clinical significance. Statistical significance, if we're talking about a group difference, is if there's a statistically significant difference, that means that we are X percentage points confident that the difference between this group and this group is not 0, right? Might it be 0.001? Maybe, but we're 95%, whatever, how confident that it's not 0. That's all it means. If it's a correlation, it's we're 95% confident that the correlation is not 0. Might the correlation be 0.1? Maybe, but it's not 0. right? That's all statistical significance tells you. So if you get a large enough sample, you can have really small differences, really small relationships that are statistically significant. But if we're looking at like treatment research, we often want to know, well, is it clinically significant? So this change in depression, time 1 to time 2, their scores came down 1 point. Well, is 1 point meaningful clinically? I don't know. You got to look at the scale. If you're looking at, okay, the relationship between maternal deprivation and depression has this correlation. Okay, well, it's a statistically significant correlation, but is it a clinically meaningful correlation? Does it explain enough of the variability that, yeah, that could be useful to know? That's helpful to know that when I'm talking to people, I need to ask about how much their mom was around when they were young. Or is it so small that it doesn't really matter? There's so many other things affecting it or related to depression that I don't need to waste my time asking that question. Another issue is this patient uniformity myth. Again, that's this myth, this misunderstanding that if these patients share a diagnosis, then they're all the same. And as we've already said, within a diagnostic category, there tends to be significant heterogeneity, significant amounts of differences. So when you're doing research on people, oh, these people have depression, and we gave them this treatment, well, they all had that label, but they may have had very different types of depression. So don't be surprised if the treatment worked for some and not for others, because you may not be treating really the same exact thing. There's some ethical limitations that are somewhat unique to clinical research. So for control groups, we've got some concerns. Obviously, if somebody, you have this intervention to prevent suicide among depressed individuals, really hard to justify having a kind of traditional control group that gets, okay, this group gets the intervention and this group gets nothing. You can't do, they're going to kill themselves. You can't do that, right? So there are ways around that. Depending on the severity and the risk, you can do a wait list control. Okay, so you're going to get treatment now. You're going to be assigned to the group that has to wait 2 weeks to start, right? That way we don't have these weird history effects where something great happened and everybody got happy at the same time. Well, if that happens, we'll be able to see that people that weren't in treatment yet also got happy, and we won't mistakenly think, oh, the treatment worked. Well, no, everybody got happy, even people that weren't in treatment yet. And then you can also do, okay, this experimental treatment versus care as usual, right? So you've got kind of a standard, here's the standard CBT we're already doing. The control group will get that, and now we just want to see this experimental treatment, is it any better than what we're already doing? Because it's not unethical to keep doing what you're doing until you know the experimental thing works. So there are ways around it. All that being said, when you're doing the research, there's still the problem of, because you have to do informed consent, right? So if you tell people, hey, we're doing a study and you're either going to be in a wait list or you can start treatment now, or we're going to say you're going to get, the standard treatment that, it's probably fine, or you get the experimental treatment, which is probably better. Now, if I'm a client and I know I'm going to be randomly assigned to one or the other, if I have more severe pathology, I've got really bad problems, I'm probably not going to take the chance that I'm going to be in the control group. I don't want to be in your study. So you're going to get people selecting out of the study when you have control groups for clinical research. So a lot of the research that's done isn't done on people with the more severe pathology because, again, they don't want to take the chance of not being in the good group or the experimental group. Replication is important across behavioral science, particularly important in clinical research, right? When a study comes out and says, oh, here's this latest, greatest thing, and there's these, of these 30 soldiers that were treated, 27 were asymptomatic of PTSD after 1 month of treatment. Wow, that's fantastic. We ought to look much more closely at this treatment. Should everybody go out and get trained in that treatment today? No, not yet. Let's do it again, right? Because our science is set up such that there is a chance that people could look like they're better and they're not, right? Where the scores change from time 1 to time 2, and it's a type 1 error, right? Where you rejected the null, but the null was true. They didn't really get better. They just looked like they were better because of some artifact of the data. So you've got to do it again. And the more you do it, the more you replicate, the more confidence you have in a finding. Last thing on this is interpreting outcomes. For treatment research, when we talk about it was successful or not successful, always look closely at how they're measuring success. Right? What do they mean? Do they mean by successful treatment? Do they mean symptom reduction? And that's often what they mean. And that's important and that's good because symptoms are often cause distress and impairment. And so we want less of them. But that's not usually the full story, right? Because if there's symptoms that are causing impairment and dysfunction and the symptoms go away, okay, well, did the impairment and dysfunction go away? So are you back at work? Are you now in a good relationship? Are you able to study now? Those things should be measured as well. Not just did the symptoms go away, but how are you actually doing? Has your life gotten better, right? Because that's the goal, is to have the happy, fully functioning life, not just to be asymptomatic. Okay, different types of research methods, pretty quickly. Case studies, not used outside of clinical research a lot, but helpful in clinical research for those kind of rare phenomena like dissociative identity disorder, where you're not going to get 30 people in a study because you're not going to find 30 people in a geographic area that meet criteria for DID. So you can work with one person and kind of give this narrative about their experiences, maybe their treatment and what worked for them. Obviously, that has poor external validity, may not generalize well to others. It's just one person, and it's not standardized in any way, but still may shed some light on rare phenomena. Correlational studies, where you're not manipulating an independent variable. You're generating, usually in these, generating some sort of correlation coefficient. If so, you're looking at the size of that coefficient and its direction. So it's going to go from -1 to 1, and the size is how far from 0. So which is bigger, a correlation of -1 or a correlation of 1? Well, neither. Those are equally large, right? Because they're both equidistant from 0. The closer you get to 0, the smaller. So a correlation of -0.4 is bigger than a correlation of +0.2. So think about absolute value for size, because that sign just tells you direction. And direction is a positive correlation or a negative correlation. Positive correlation means they covary in the same direction. That means that, okay, these two things are positively correlated. If you're high on one, you're going to be high on the other. It also means, don't get tricked here, if you're low on one, you're low on the other. Right? It doesn't just mean always high and high. If high and high, then also low and low. So they covary in the same direction. Negative means they covary in opposite directions. So if you're high on one, you'll be low on the other. If you're low on one, you'll be high on the other. Most important thing to remember about correlation studies, though, is that you cannot infer causation from correlation. Right? This is because of the directionality problem and the third variable problem. The directionality problem has to do with if there's a correlation between A and B, between depression and anxiety. Okay, does that mean that depression caused anxiety? Maybe. Or did anxiety cause depression? Well, maybe. We don't know which way the directional arrow flows, just because there's a correlation. The other thing is this third variable problem. Sometimes two variables are related, but they're not related in any kind of causal sense directly. It's that there's some third variable, A causes B and B causes C. So, there's a positive correlation between number of ashtrays in a person's house and risk for lung cancer. Does that mean that ashtrays cause lung cancer? Well, no, that's ridiculous. But number of ashtrays is correlated with smoking, because if you smoke a lot, you're going to buy more ashtrays. So smoking behavior causes the number of ashtrays. Smoking behavior also causes cancer, right? So there's this third variable that causes both these two things, which makes them correlated. So because of the directionality problem and the third variable problem, we can't assume causality from correlation. Does that mean if two variables are correlated, there's no causation? No. It just means you can't assume it. There might be. That means there's possibly causation, but we got to do an experiment to find out. So experiments we've already talked about. To do one, you have to have a control group and experimental group. You have to have the power to assign participants to levels of the independent variable. And you need to do that with random assignment. and then you have to exert experimental control, right? So you have to treat people as similarly as possible in the two groups, except for the independent variable. Everything else, same, eliminating confounds. Single case experimental designs, or single subject designs, sometimes referred to. Again, not real common outside of clinical research, but pretty helpful in clinical research, especially for some kind of behavioral interventions. So this is whenever you want to be able to establish causal relationships among variables, but you don't want to go out and gather 30, 40, 50 subjects. You're working with one person. So this may be you've got a kid engaging in self-injurious behavior, doing some head banging, right? So one of the hallmarks of this type of design is repeated measurement. So before we do anything with this kid, we're going to establish a baseline. So we're going to measure how much head banging on day 1, day 2, day 3, and we're going to look at those data before we do anything else. So are they head banging roughly the same amount, or was it high one day, low the next, high the next, right? If there's any kind of fluctuation, we got to figure out why. What's going on? What made it go down? We got to gather more data. But if it's stable, okay, it's stable. This is how much they're doing it. Now I can say, okay, let's see if we can change it. So now I'm going to introduce an intervention. And I introduce the intervention, and then I measure another 3 days, right? And I say, okay, did head banging now go down over those 3 days? And then if it does, cool. Now, if I really want to be confident that I'm about to, tell everybody this is the best intervention, you got to do it. Well, could be a coincidence, right? Maybe that kid stopped head banging when you do the intervention because of something else. Maybe it's because, hey, there's somebody new in my life and they're paying attention to me. Cool. So if you use a withdrawal design, you do everything else that you can. You're still there talking to them, but you stop doing the intervention. You withdraw the effective component of the intervention, and you keep measuring, right? And you see if head banging goes back to the earlier level. If it does, okay, well now obviously you reintroduce the intervention very quickly, but you also have now demonstrated experimental control, and now you're fairly confident, at least for this kiddo, this thing worked and it caused them to headbang less. If you're worried about this, the ethics of the withdrawal design or reversibility, you can also do a multiple baseline design, right, where you're measuring multiple behaviors or multiple individuals. But one of the simplest ways, multiple behaviors. So headbanging, the kids are maybe also doing some spitting, and then also maybe not cleaning the room, whatever. You're measuring all 3 different things, and then you have an intervention after you establish baseline to target just one of them, right? And if you see the one behavior you target change and the others don't change, well, if it was just somebody being present in their life, all the things should change, right? But you just targeted the one with the intervention, so nope, these 2 didn't change. And then after a week, maybe, okay, now you target another behavior, and if it starts to change after you target it, okay, now you started to, again, establish some evidence of control and of a causal relationship. Again, with one person, and even though it says single case, it's often done with 2, 3, or 4, a couple of people. So it can be a very valuable tool in clinical research. Okay, studying genetics. A lot of the studies are done with family studies, right, where you identify a proband. So the proband, excuse me, is the family member that has a particular trait, right? So if we're looking at like schizophrenia. Here's this one person in a family that has schizophrenia. Now we're going to look at other people in the family that are related to that person to different degrees, right? Have different levels of genetic relatedness, right? Obviously, identical twin, most related, non-twin sibling, less related, cousin, first cousin, less related, second cousin, even less related. And we look at, okay, as we look in their family circle, and we have lots of people looking in lots of family circles, as we go from more genetically related to less genetically related, do we see differences in the frequency of this other person having schizophrenia, right? And when they both have it, if somebody else has the trait as like the proband, we talk about that being concordance. So we're looking at concordance rates. So they're both concordant for schizophrenia. And typically what you find is that there are higher concordance rates among people that are more closely genetically related to the proband. Typically, not always, but there's certainly a statistically significant trend. There's also some valuable information from adoption studies. And again, these are not super easy to do, but where you've identified a kid that has typically meets criteria for a psychological disorder, and or their biological parent met criteria for a psychological disorder. They're adopted out of that home at an early age, and then look and say, okay, what happens to them versus looking at kids that weren't adopted, that have a parent with that particular diagnosis. Okay, how many of them later develop that disorder? And we're then looking at trying to tease apart this genetic versus environmental influence. And then with that, obviously also looking at twin studies, both with adoption twin studies, family studies with twins, with the assumption here being that if these monozygotic twins that are 99.9% genetically identical, if there's higher concordance rates among them than non-identical twins or non-twin siblings, then that's evidence of the influence of genetics. And it certainly is some. It's probably not as strong evidence as people make it out to be, because they say, oh, well, if they're more similar in terms of their concordance rates, that's because they're more similar genetically. Because they have these two twins have the same environment as each other, but we're comparing them to siblings, and these siblings also have the same environment. Well, how same, right? Two identical twins are going to have much more similar environmental experiences to each other, right? Often dressed alike, treated fairly similarly because they look alike, right? If they're very attractive, they'll both be treated well. If they're both ugly, they'll both be treated poorly. Versus these non-twin siblings, one could be highly attractive, one could be ugly. They're probably going to dress differently. They're maybe different age. They could be different genders. And if you don't believe that boys and girls experience different environments, well, I got some news for you. They certainly do. So not only do these twins have more genetic similarity, they also have some more environmental similarity. So you can't say that, oh, if there's high concordance rate, that's totally because of genetics. Well, you haven't really teased apart that environmental part, and you just practically can't, except for those twins reared apart studies, which are pretty rare, pretty far between, few and far between. So genetics play a role, but we have to be careful about how far we extend the conclusions drawn from those things, because they get pushed a little further than probably should. Genetic linkage analysis, something that they're working on, trying to identify particular genes or combination of genes associated with disorders, looking at genetic markers, right? So, and sometimes this is, they're not even looking, okay, this gene causes schizophrenia or causes depression, but when people have depression, they have these gene markers without any kind of assumption about that gene being involved in the etiology, but more looking at it as a kind of a flag, like, hey, this may not cause it, but it seems to be there a lot. And typically when they identify these genetic markers, especially for schizophrenia, there's a lot of excitement in the field. Hey, we found it, here's the marker. And then a month later, somebody comes and says, you know what, nope, that's not a good marker. Here's all these people with schizophrenia that don't have it. Here's other people that have it, they don't have schizophrenia. So I'm a little pessimistic about that research, but maybe. And then association studies, ones that compare people with and without a disorder to see if genetic markers are more common in one group than the other. These genes may be close to the ones that are responsible, but again, our understanding of genetics probably not as far along as many of us thought it would be by this time. Lastly, looking at studying behavior over time and across cultures. So you have cross-sectional designs. This is where you're looking at people in different cohorts, right? So people who were 20 in 1980, people who were 20 in 1990, people who were 20 in the year 2000, and comparing those individuals, which obviously leaves you open to possible cohort effects. So if you see, okay, these people born different times in a cross-sectional design, I'm measuring them all at one point in time. So I've got these 60-year-olds, 50-year-olds, and 40-year-olds, and I'm saying, okay, well, looking at the 60, the 50, the 40, I see these differences. So as you get older, this happens. But it may not be an aging thing. It may be a cohort effect where, well, actually these people, well, when they were 12, that's when the Twin Towers fell, and that affected their development. And that's why when they're 60, they look like this. Has nothing to do with getting older. Has to do with that actual cohort of people. So that can be misleading about changes in abnormal behavior across time if you're looking at cross-sectional designs. More helpful to look at longitudinal designs, which are obviously expensive and time-consuming to follow people across time. Excuse me. But even with that, you may have to worry about cross-generational effects, and that's the idea that the generation that you followed across time might be different than others. Again, there's something unique about them. Okay, here's this process that as you get older, this happens, and that may be true for that group, but does it generalize to other people, other cohorts, basically? So one solution, the big expensive time-consuming one, would be do a sequential design or cross-sequential design, where you're combining cross-sectional and longitudinal. So you get 10-year-olds, 20-year-olds, 30-year-olds, and you follow all three groups across time for 30 years. Okay, well now you can tease apart all those cohort effects, cross-generational effects, and really figure out how people change across time. Which we probably don't have enough data on in terms of abnormal behavior. Not enough longitudinal or sequential designs. Some on depression, a little bit on schizophrenia, but a lot of the other ones missing a fair amount. It's also important to do research looking at cross-cultural comparisons, right? And not get hung up with our assumptions about, okay, well, this is what I'm like, everybody's like that, right? That's our tendency to be kind of ethnocentric. It's important to recognize there are these differences, and when we're trying to do this research, one kind of thing that's important to be sensitive to are these translation issues. When we're using these psych assessment tools that are written in one language and translated to another, you've got to have somebody that's not just a translator familiar with both languages doing it, somebody who's a translator and is also familiar with the psychological concepts being studied, because oftentimes there's some unique language in there that, oh, this is the literal translation of this word, but the meaning intended to measure a particular psychological construct is lost. So there's a whole process for developing culturally appropriate measures to do cross-cultural research. Okay, take-home messages. In terms of assessment, it's important to do, we talk about lots of methods, and it's not which one's best, it's all of them. Multi-method is best, multi-method, multi-informant. So you want self-report as much as possible, you want other report as well, and different methods from these different informants. That's what's ideal. Keep in mind the story of the blind men of Indostan, right? When you're doing assessment, if you're just looking at one thing in one way, you're not seeing the whole picture. You've got to have a more holistic view, or you're going to be misled. In terms of diagnosis, it's a decision process that leads to a decision. It is not a truth revelation, right? So as we're talking about these things, oh, these people diagnosed with schizophrenia, again, that's why we don't refer to them as schizophrenics, because that's not what they are. They're people that were, somebody said, met criteria for this disorder. And that's different than saying you are this thing. That's not their identity. It's not, because we don't even know if the decision was correct. All we know is the decision was made at some point in time. Somebody thought they were exhibiting enough symptoms to meet criteria for this diagnostic decision to be made. Okay? Always keep that in mind. Last, in terms of research, we went over quite a lot very quickly, but it is important, and make sure you take research methods and do well in it. You've got to be equipped to think critically about research findings, because there's a lot of findings out there, and if you don't know the verbiage, you don't know the language, you don't know the ideas and the concepts to a level that makes you kind of a literate consumer of research, then you're left relying on authority. Well, they said they found this, and that sounds good, right? You might as well read in the National Enquirer. Again, most of these journals you'll be reading things from, they're not trying to fool you or lie to you, as some tabloid journals might, but they are writing from a particular perspective, and they do have some bias. There's some answer they're looking for, and it may not be the truth. So you've got to have a critical eye looking at all research. But to have that critical eye, you've got to have some knowledge, and it's something I think everybody can work toward building. Okay, that's all for now. Take care.